సార్
బాగా మీరు ఎప్పుడు మొదలు పెట్టమంటే అప్పుడు మొదలు పెడతా.
సార్ డన్ సార్.
సార్ స్టార్ట్ చేద్దాం లేదు సార్.
ఓకే సార్. So dear friends, good evening and welcome to our Wednesday webinar, Young Mind Summit. Before the webinar, let us have a brief inauguration of our first newsletter. The purpose of bringing out newsletters is mainly our members, entire state are actively doing number of awareness and academic activities for any like suicide day, Alzheimer's day, all those things. So it should be recorded and duly be recognized. That is one purpose. And all our activities will be kept in our website and it will be communicated to the state as well as national bodies. We are really grateful and profusely thankful to our communication committee members, Dr. NG Nihal and Dr. Rufus, for their enthusiastic and dynamic efforts to bring out the beautiful newsletter. And we are planning to bring such newsletters. We'll bring out another newsletter in IPSAP PG CME 1 and midterm CME another, and last again another annual conference, fourth one. So quarterly, every 3 months. With this brief introduction, I request our respected South Zone President, Dr. K Uday Garu, and young dynamic South Zone Secretary, Dr. P Lokeswara Reddy Garu, to announce the inauguration, and it will be done by our people. If you announce it, they will do it.
Okay. Sir, may I, sir?
Yes, sir. Sir, Uday, sir.
May announce it, sir.
Okay. From my side, first of all, let me congratulate the whole IPS AP State Branch office bearers, the team of Dr. I Vishal Garu to bring the beautiful newsletter of AP State Branch. So I heard that it would come once in 3 months of entire this tenure. I think committee members Rufus and Nihal are extremely doing good. That's what I heard from I Vishal sir. I think they are supposed to upload all the information about the newsletter contents to the website and to be sent to the either to the state branch and to the South Zone branch. In turn, we would send it to IPS level office bearers. So that I expect with this information what these communication committee people are doing extremely. I hope that we would get the best state award this time, sir. There are n number of benefits with newsletters, sir. It connects to all the members with all the good recent and past informations, events, programs, awareness programs, all the details we would get, and then conference details about the past and future about our traditional conferences. Details would get into touch with to all the members, and it increases the credibility and authority. I think definitely it gets motivated to all the members to do such beautiful programs towards psychiatry. Sir, I am very happy that once the people read about the reliable sources of information, when you read, you feel very happy, sir. So newsletter content becomes the very reliable sources of information. So I congratulate AP State Branch office bearers and especially Rufus and Nihal for bringing this beautiful newsletter into the limelight to all the members. I think I expect it would reach to all the members by post or WhatsApp thing, and then will be uploaded to a website even of the both the groups, state and journal level. Sir, with this information, I have a strong hope that we would stand. Last time we supposed to stand as best zone, best state branch, but we have missed. But this time, I think we would get best state branch award, sir. So with this, I announce that along with my secretary, Dr. Lokeswara Reddy garu, that this newsletter of AP State Branch is open, inaugurated rather. Thank you, sir.
Thank you, sir.
Yeah, Rufus and Nihal, will you speak something about your efforts?
No, no,
Sir, Lokeswara sir మాట్లాడాలి sir. Lokeswara sir.
Okay, Dr. Lokesh ji.
So good evening, everyone. I congratulate our own state branch for bringing out the newsletter. I think after becoming the secretary of the South Zone, I felt that compared to seeing the newsletters of other states, I felt that we were not up to the standards where we should project our activities. In spite of doing many activities, we were lacking behind in projecting the activities to the state or the zonal and the next national level. I think this is a very good step taken by the office bearers of IPSAP state branch and the youngsters, Dr. Nihal and Dr. Rufus. I think they're doing a wonderful job. And even now I see I have gone through the newsletter. I think we are reaching the standards of all the other state branches which have been continuously winning the best branch or the second best branch or the third best branch. So I think with this start, I think we can go much ahead and try to incorporate all the activities. And even, I mean, a suggestion like thing is like we can organize the organizational activities at one place, community activities at one place,
Yes.
zonal activity, I mean the academic activities at one place, so that can give more information to the zonal. As this is the first one, I think this is a very good beginning, and I congratulate and wish all the best to our own state branch and both the youngsters Nihal and Rufus, and also the secretary who has taken initiative to, and the president IVL sir who have chosen the right people. I feel I think they can take the newsletter much forward, and hopefully we'll win the one of the prizes in the national level. Thank you very much.
Thank you, sir.
Any senior members can express their view, like IRS sir if he has come, or Prabhakar sir. No? Okay.
Only who are in the panel list can talk, sir, actually.
Okay. Then Nihal
Ramana Rao sir is there.
Ramana Rao sir. Ramana Rao garu.
Sorry, sir.
You want to talk?
Any views about
this newsletter? Huh?
Yes.
Yeah, it's excellent, and I have seen some of those pictures. Everything is very good, and Dr. Nihal and Dr. Rufus, they're taking extraordinary care, and I appreciate and I wish the committee a grand success, because this was inaugurated by our beloved Dr. Uday Kumar garu. I'm sure it is going to be highly successful program for IPS. Thank you very much.
Now I request Dr. Rufus and Dr. Nihal, the editors of the newsletter.
Sir, good evening, sir. Am I audible, sir?
Yeah, you are.
Sir,
Yes.
a very welcome to all the dignitaries who has joined the today's meeting, sir. And first of all, we would like to thank our President Garu and Secretary sir for believing in us and giving us this responsibility for both me and Nihal. And I thank especially all the psychiatrists, co-psychiatrists who have organized many activities for our state branch and people who have sent their activities to the communication mail which we have given. And also we have taken every efforts and pains to assemble all and assimilate all the data given to us and bringing out this newsletter. And if we have missed by chance anybody, we are extremely sorry, and that is very highly unintentional. And we hope we will include that in the next forthcoming newsletter also. And I request all the my colleagues to organize various activities for the upcoming World Mental Health Day and send their details to the communication address which you have sent priorly. And I thank my colleague Nihal and also my mentors and everybody who have helped in bringing out this letter. Thank you so much, sir. Thank you. Long live IPS.
Sir, good evening, everyone, sir.
Sir. Nihal ji.
Sir, నేను డాక్టర్ ప్రభాకర్.
ప్రభాకర్ మాట్లాడండి
సార్ ఇదే వీడియో ఎందుకు రావట్లేదు. సో ఐఎమ్ ట్రైయింగ్ సిన్స్ లాంగ్ టైం. సో ఎనీహౌ
సార్ బేసికల్ అంటే సార్ మీరు పేరుతో రాలేదు కదా, అందుకోసమని వివో అని పడుతుంది సార్, అందుకోసమని మేము ప్యానలిస్ట్ మార్చలేదు సార్, అందుకు ఇప్పుడే మార్చాం సార్ ప్యానలిస్ట్.
ఓకే, థ్యాంక్ యూ సార్. కంగ్రాచులేషన్స్ ఆల్ ఆఫ్ యూ.
చెప్పండి ప్రభాకర్
సార్, కంగ్రాచులేషన్స్ ఆల్ ఆఫ్ యూ. ఈజ్ అ లాంగ్ డ్రీమ్, ఇది పెండింగ్ డ్రీమ్ అనమాట. ఈ రోజు మీరు ఫుల్ఫిల్ చేశారు. మీరు తీసుకున్న తర్వాత యాక్చువల్ గా రమేష్ బాబు సార్ చాలా సార్లు అడ్వైజ్ చేశారు. ఆ తర్వాత కానీ ఆ టైంలో మేము దాన్ని ఎందుకో దీన్ని తీసుకురాలేకపోయాము, రెగ్యులర్ గా తీసుకురాలేకపోయాము. మీరు మీరు చార్జ్ తీసుకుని వెంటనే మీరు ఒక మంచి డైనమిక్ యంగ్స్టర్స్ ను, ఇంట్రెస్టెడ్ క్యాండిడేట్ ను మీరు అపాయింట్ చేయడం, వాళ్ళు యుద్ధ ప్రాతిపదికన అన్ని కలెక్ట్ చేసి ఎప్పుడప్పుడు అప్డేట్ చేయడం రియల్ గా గ్రేట్ సార్. దీనికి ఒక షార్ట్ పీరియడ్ లోనే మీరు న్యూస్లెటర్ తీసుకురావడం నిజంగా గ్రేట్ థింగ్. సో కంగ్రాచులేషన్స్ టు ఆల్ ఈసీ మెంబర్స్, ప్రెసిడెంట్, సెక్రటరీ అండ్ ఈ న్యూస్లెటర్ తీసుకురావడానికి బాగా ట్రై చేసినటువంటి వాళ్ళందరికీ కూడా హార్ట్లీ కంగ్రాచులేషన్స్, ఆల్ ది బెస్ట్.
థ్యాంక్ యూ. నిహాల్ మీరేనా మాట్లాడతారా?
Sure, sir. Good evening, respected seniors and esteemed colleagues. I would like to extend my heartfelt appreciation to all those who have contributed to this newsletter. As IVL sir said, the main purpose of this is to keep us all informed about the activities that have been taken by the psychiatrists of the IPS state branch, and also to report them to the zonal as well as the national body, which serves as a testament to the hard work and commitment of our psychiatrists in creating awareness. And this newsletter mainly covers the activities that are undertaken by the psychiatrists up to 15 September. That includes the Suicide Awareness Day as well. At this outset, first and foremost, we must acknowledge the support and the trust of our President, Dr. IVL sir, and also our Secretary, Dr. I Sharchandra sir. When the national IPS newsletter was released, IVL sir shared it to me and said that I want our society to release such a beautiful newsletter as well, and he entrusted the duty on us. I think it's their belief in our capabilities and entrusting us with the task to produce this newsletter has been quite a pivotal role. We owe them a great debt of gratitude for their guidance and encouragement. I hope we lived up to your expectations, sir. And also at this outset, I would like to thank our sincere thanks to Uday Kumar sir, our South Zone President, and Dr. Lokeswara Reddy sir, our Secretary, for gracing us their presence and support during the launch of our newsletter, despite having their busy schedules. And we are also indebted to all those who have reported their activities to our designated email address, IPSAP communications@gmail.com. The contributions have been invaluable in ensuring the comprehensiveness and information of this newsletter. To conclude, we hope that you find this newsletter engaging We would be happy if we receive some feedback and suggestions, as they would help us to improve and tailor future editions. And I sincerely apologize if inadvertently any of the reported activities were overlooked. I would also like to thank Rufus sir for constantly encouraging and supporting me, and also would like to thank everyone for giving this opportunity. Thank you.
Thank you, Nihal. Dr. Lokesh Reddy has given wonderful advice. We have to divide organizational activities, awareness activities, academic activities, and forthcoming events. As Dr. Uday said, we have the same way of presenting it in the next newsletter. Okay. Now, I request Dr. Kishore to hand over the proceedings to Dr. Ramana Rao garu first, and then Dr. D Phanibhushan, a chairperson. Kishore.
Okay, sir. Sir, good evening, everyone.
Yes,
very happy to. Good evening, everyone. Very happy to invite you for this academic session. Before we go to CME, Nihal, can you share the video of the newsletter? I think Sharad Chandra has sent. Can you share the video? So newsletter in the form of video, sir. Just a video, just 1 minute 30 seconds video.
Yeah.
Sharad sir insisted me to play this video in the meetings. What about audio? Audio రావట్లేదు.
సార్ ఇక్కడ నాకు వస్తుంది సార్ ఆడియో.
ఓకే.
ఇక్కడ రావట్లేదు.
అక్కడ ఒక ఆడియో అని ఉంటుంది సార్, సెలెక్ట్ చేయాలి. అన్సెలెక్ట్ అయితే అన్సెలెక్ట్ చేయండి, అన్సెలెక్ట్ అయితే సెలెక్ట్ చేయండి.
మళ్ళీ షేర్ చేయాలా?
మళ్ళీ షేర్ చేసినప్పుడు కింద ఇఫ్ ఇట్ ఇస్ సెలెక్టెడ్ అన్సెలెక్టెడ్, ఇఫ్ ఇట్ ఇస్ నాట్ సెలెక్టెడ్ సెలెక్టెడ్. షేర్.
సౌండ్ రావట్లా.
సార్
Kishore, sound రావట్లేదు.
అవును సార్, రావట్లేదు సార్. We'll post this video in the IPSAP activity group, sir.
Okay.
As we will go to the CME session.
అట్లా. Ashok Nagireddy, Anand from Tanuku, Dr. Umajati from GGH. Okay. The newsletter is printed by Crescent Pharma. Thanks for their support. Okay, Kishore.
Okay, sir. Sir, good evening, everyone. It's my pleasure to invite GV Ramana Rao garu to start the CME proceedings. Sir, please lead the CME sessions.
Thank you very much, Dr. Kishore. Dear colleagues, it's indeed a pleasure to speak few words on the consultation in psychiatry, which is a special subspecialty in the US and Europe. And long back, 400 BC, Plato lamented that today's physicians separate the soul from the body. The same thing holds even today also. Famous personality in the CL psychiatry, that is Lipovetsky, explained that CL psychiatry provides a vantage point for watching the changes that permit prediction of the future direction in psychiatry as a medical specialty. As we all know, CL psychiatry is something very special to only one of the specialties of medicine, because we don't have a CL cardiologist, we don't have a CL neurologist, but why should only a CL psychiatrist? That is a question posed by Norman Sartorius, the famous editor of the ICD, 10th edition. He says that we psychiatrists have de-skilled ourselves and we stopped examining the patients. And that is the reason why a subspecialty like CL psychiatry has come. Actually, in clinical psychiatry, we are supposed to be exposed to various branches of medicine along with neurology. So naturally, we expect that we are supposed to screen our patients and we are supposed to do whatever that is necessary and refer to the other colleagues. But unfortunately, we have become more like, talking doctors and we stopped examining the patients. That is the reason why the CL psychiatry has come up. CL psychiatry was there since long time. As I told you, even Plato has lamented. Then we have got so many American psychiatrists who have promoted it. But unfortunately, it has got a very bumpy road. It was there in the loop line sometimes, it was there in the mainstream sometimes. So ultimately, now it is recognized by in several countries as the subspecialties. And I think even in our own country, there are people like Nimhan's courses in like postdoctoral fellowship are being offered. And nowadays it is in the limelight. In fact, it is considered to be as the fourth revolution because first is the moral treatments and unchaining of the patients. And then the second one is the ECT. And the third one is the psychopharmacology. And this one is the fourth revolution. But unfortunately, we are not really catching up to the expectations. It's a very, very important subspecialty of psychiatry. And I'm sure all of us will really put into practice so that our patients will be benefited. And our specialty, like clinical psychiatry, will be highlighted among the medical specialists and our other colleagues, medical colleagues. And usually, the common problems which we see in clinical psychiatry, CL psychiatry is categorized as Ds, like, D means dementia, delirium, drugs related complications, depression, and then decision making, like, for example, capacity requests to accept or refuse care or leave against medical advice. Even there also, the role of the psychiatrist is very much there. That's why the psychiatrist is being consulted whenever a problematic patient is being presented in other medical wards or surgical wards. And we are supposed to identify and treat the main psychiatric disorders as well as some of the related medical concerns also we are supposed to address. And also we are supposed to see, as I told you, difficult patients and difficult behaviors, especially malingering, factitious behaviors, conversion disorders, and borderline personality disorders, and other things like. And also psychiatric referral rates are very, very, very minimal in India. And even though we know that in ICU, there are almost 70 to 80% of the patients have delirium, but hardly a psychiatrist is being consulted. And also in various setups, like, in inpatient setups, more than 50% of the patients that require the psychiatric consultations, but hardly were being consulted. So there are several barriers for this, like barriers at the level of the physician, barriers at the level of the psychiatrist, and also barriers at the level of the patient himself or herself. So these barriers, I'm sure we are going to, our colleague, Dr. Kiran, is going to point out. And there are several newer developments in consultation liaison psychiatry, especially in the field of psycho-oncology, because we see lots of patients with the terminal illness developing depression and other psychiatric complications. And there are issues like drug-drug interactions with oncology medication also. And also, upcoming branch is the transplantation medicine, which I understand very expensive in the US. And there, the psychiatrist role is very much needed, especially in the capacity testing and fitness for the transplantation, both in the donor as well as the recipient. It has to be certified by a CL psychiatrist. And also in palliative care centers, the CL psychiatrists administer meaning-centered psychotherapy in the context of end-of-life situations. And also nowadays the CL psychiatrists are entering into the primary care also. And they are being integrated in the team, and routinely they treat depression, anxiety in the OP setting also. And it is now moving CL psychiatry from ICU to inpatient care to OP also. This is a very welcome step, especially in the developed countries. In our own country also, especially places like small towns, the psychiatrists have got a very large role to do all these things. Still, psychiatry work in collaboration with pulmonologists, sleep medicine specialists, especially in the management of obstructive sleep apneas and primary insomnias and parasomnias, is very well established, and we need to work on that rather than prescribing hypnotics for insomnia patients. Sometimes most of them have OSS, and we will be doing great injustice if we don't work it up. So we need to collaborate with other colleagues, and then we need to do needful things. In the same way, we need to collaborate with our neurology colleagues in the management of dementia and delirium also. And also pain medicine also, there is a lot of role for the consultation legend psychiatrist, HIV psychiatry also, and all branches of medicine like obstetrics, gynae, perinatal psychiatry, perinatal, whatever you call any branch of medicine or surgery, there is a role for SEL psychiatry. So apart from that, there are a lot of academic activity going on in CL psychiatry, especially in the US also. They allow in some of the centers, even the international colleagues to join in CL psychiatry for postdoctoral fellowship. Of course, they won't allow us to practice there, but they allow us to get trained in that. And also, there is a lot of opportunities in the research in the CL psychiatry. And I'm sure Dr. Kiran and our own chairperson, Dr. Phanibhushan, they're going to elaborate on that. I know that Phanibhushan is an expert in the field of CL psychiatry, and we all of us have heard his talk on in Manasa Hospital oration, I think a couple of years ago, which is a wonderful, one of the best orations which we have ever heard. And he has conducted even two big CME programs as late as 2 years ago in NRI Medical College. Excellent topics related to CL psychiatry. And 20 years also, I think if it is something like 20 years, he has conducted another CME program in Guntur, which is one of the best CME programs so far conducted. So with this introduction, of course, which is a little bit lengthy, but since we have some time, I have taken advantage. Now I request our chairperson, Dr. Phanibhushan, to take his charge. Thank you very much.
Yeah. Good evening, each and every one of you. I was following. I was wondering whether I think you did the most work, and my work has been become less because of your versatility in dealing with any subject. Thank you, Raman Rao, for your beautiful introduction of the CL psychiatry. As you are aware, the consultation psychiatry is one side the art of psychiatry, on another side the rigors of general medicine, and the CL psychiatry is a kind of interface between the two, and we have multiple roles to fulfill, and we should be good doctors, physicians first, and you should be aware of what is happening as far as the updates are concerned in different fields of medical and surgical specialties. If you don't keep tag on what is happening in the other specialties, you will become a dud fellow, and you can't do anything. So I keep telling my students that psychiatrists should have a sound knowledge on other specialties also. Particularly, they should have the knack of finding out, identifying the earliest features, non-specific features or soft signs in each and every super specialty or subspecialty. already super specialties have realized the importance of consultation of the role of psychiatrists in their day-to-day work. And I think it's a wonderful subspecialty, provided you know your job. So without the speaker is very eager to talk on various issues of this beautiful subject. So I hand over the mic to Dr. Vaddadi Venkat Kiran, Associate Professor of Psychiatry, Government Medical College, Guntur Medical College, Guntur, to deliver his lecture so that we can add some of the issues at the end of his presentation. May I request Dr. Venkat Kiran, who is a graduate from RMC Kakinada and postgraduate from GSL Medical College under Dr. K Ramana Reddy garu, and he is going to deliver his presentation on CL psychiatry, its present role, and the other basic issues and the burning conflicts or issues regarding CL psychiatry. Over to Dr. Venkat Kiran. Thank you.
Thank you, sir. Hope I'm audible, sir.
Yeah.
Yeah.
Yes, sir, you are audible, sir.
Sir. I think most of the job was done by Ramana Rao, sir, and Phanibhushan garu, sir. Basically, yeah, I'm a bit tensed, and there are a lot of technical issues happening around because I couldn't connect the screen properly. So, respected seniors, colleagues, juniors, PGs, ladies and gentlemen, thank you very much for giving me this opportunity. And today my topic is consultation, liaison psychiatry, challenges in clinical practice. I'm taking help of Lokesh garu in guiding me with the slides. Sir, can you play it in the full screen, sir? There is a play option on the top, I see. Yeah, thank you, sir. Thank you. So, can we go to the next slide, sir? So, before I start, I would especially thank Dr. Phanibhushan garu for sharing his views and opinions, Dr. Lokesh Sharath and Dr. Sai Kiran for providing loads and loads of material, Dr. Farhat for compiling and rephrasing my case data, and Akhil and Dr. Balu, my PGs, for the clips and images, Dr. Hema Malini, my wife, for asking a brilliant and thoughtful question, and Dr. Hanuma Srinivas Reddy, neurosurgeon, for providing me a platform to run the hybrid model. And so don't go fast, sir. So yeah, and Dr. Darpan, Dr. Bhaskar Mukherjee, and Dr. Rukshita for guiding me. So next slide, sir. This is a small disclaimer, and we all agree to disagree, but next time let's agree to understand. So when this topic was given to me, consultation, liaison psychiatry, it was quite overwhelming and panicking at the same time. But the cherry on the top was when I saw challenges in the practice. Can we go to the next slide, sir? So the first thought I got was this. Next, please. Aswadama hataha kunjraha. Because next one, please. We all do have elephants in the room. So let us start addressing the uncomfortable truths. I know my presentation is going to be a little different, maybe an out of box thinking. So in this presentation, I'm going to deal in 3 parts. The first part would be the concept and origin of your consultation liaison psychiatry, and the second one would be the scenarios in India, and the third part would be my challenges. So since it is for the young minds, my PGs and all other young colleagues, let me give a brief introduction on consultation liaison. The consultation liaison psychiatry is relatively young but vibrant and upcoming subspecialty of psychiatry. The term CLP is often used interchangeably with psychosomatic medicine, which deals with the understanding of the interplay of biological, and psychosocial factors in the development, course, and outcome of all diseases. The history of psychosomatic medicine can be tracked back to Johann Henroth, who coined the term psychosomatic in 1818, but few years later, it was in 1922 that Felix Dusch gave the concept of psychosomatic medicine. Next, please. So the term liaison psychiatry was used for the first time by Billings during the organization or the pioneering phase. In United States, basically it is divided into 4 phases. Each phase roughly lasts for around 30 years. It is a preliminary phase, organization and pioneering phase, developmental phase, consolidation or retrenchment phase. Next one. Next. Yeah, understanding the term consultation liaison. Next one, please. See, according to Lipovsky, the designation of consultation liaison reflects 2 interrelated roles of the consultants. Consultation refers to the provision of expert opinion about the diagnosis and advice on management regarding a patient's mental status and behavior at the request of another health personnel. The term liaison refers to linking up of groups for the purpose of effective collaboration. In the context of current CL psychiatry, liaison involves interpretation and mediation, that is, the consultant psychiatrist mediates between the patients and members of the clinical team and between mental health and other health professionals respectively. Next one. However, it is important to understand the differences between the terms CL psychiatry and psychosomatic medicine. Psychosomatic medicine, as I said, is conceptualized as a non-clinical discipline that is concerned with ideas such as the interplay of biological and psychosocial factors in the development, course, and outcome of all diseases. Hence, some authors consider CL psychiatry as a practical and clinical arm of an applied form of psychosomatic medicine. Now, the CL psychiatry has 2 primary functions. One, to provide an expert advice on the referred patient, and that of a liaison or link. Second, on the liaison part of CL psychiatry denotes its educational function, which includes education for patients, requesting physicians, nursing staff, patients' families, and the healthcare system. The role of functions of a consultation liaison psychiatrist encompasses your clinical work, teaching, administration, and research. The clinical work includes facilitation of the medical treatment of the patient. A CL psychiatrist is expected to be a medical expert, a good communicator, good collaborator, a manager, a supervisor, health advocate, professional, and a scholar. The CL psychiatrist is expected to enhance the knowledge of the trainees in psychiatry and other specialties and enhance the awareness of members of medical and surgical team with respect to the mental health issues. Now, coming on to the models of consultation liaison psychiatry, we have few. The various models of CL services have been developed. According to the focus of consultation, it is patient-oriented approach. There is a crisis-oriented, consultative-oriented approach, situation-oriented approach, and expanded psychiatric consultation. And based on the function, next one please. We have a consultation model, a liaison model, a bridge model, a hybrid model, and autonomous psychiatric model. Next one. Yeah, as per focus of work, we have critical care model, biological model, milieu model, and integral model. Next one. The biological model lays emphasis on neuroscience, psychopharmacology, and psychological management. I'm just picking up the important models that are going to be useful for us. The milieu model is based on interpersonal theory and involves group aspects of patient care, reaction and interaction of staff, and understanding of ward environment. The integral model is usually agency-based and involves providing psychological care as an integral factor of clinical and administrative needs. In most of the Western countries, CLP services have a multidisciplinary team, which is led by a consultant liaison psychiatrist with a mental health nurse, clinical psychologist, occupational therapists, and social workers as their other team members. In recent times, depending on the scope of CLP, our Royal College of Psychiatrists have described Core 24, Enhanced 24, and Comprehensive CL Psychiatry Services. Next one, please. Now, the consultation liaison psychiatry is focus important. Yes, with the increase in lifespan, there is an increase in geriatric patients, ethical and legal issues encountered in medical practice, encompassing issues such as euthanasia, of course it is not in India, organ transplantation, gender reassignment surgeries, and CLP can also help in enhancing the knowledge of mental health professionals in terms of forensic issues. Next one. Now, the contributions of consultation, liaison, psychiatry. CL psychiatry research has made major contributions to practice of medicine. CL psychiatry has brought forward the concept of psychiatric sequelae of medical disorders, contribution of psychiatric manifestations to the etiology, course and outcome of various medical illnesses. There have been landmark studies in diabetes, HIV, AIDS, coronary artery diseases, cancer and stroke. CL psychiatry has also highlighted the issues of management of various psychiatric disorders in the presence of comorbid medical illness, drug interactions of psychotropics with other medication, and as well as medication-induced psychiatric symptoms. Research in the field of CLP has shown the importance of recognizing mental illnesses among medically ill patients, and there is evolution of terms that has already been mentioned by our GV Ramana Rao, psycho-oncology, transplant psychiatry, psychonephrology, and cardiac psychiatry. Next one. Now let us look at the other side of the coin. Coming to the emergence of general hospital psychiatric units vis-a-vis consultation liaison psychiatry in India. This goes my second part. Now, everything I mentioned in this itself is a challenge in our practice. In India, mental health services were limited to the confines of mental hospitals up till the 1930s. The first GHPU was started by Dr. Girendra Shekhar at R.G. Kar Medical College and Hospital, Calcutta in 1933. CL psychiatry made a beginning in India on par with other countries when it was in the organization and pioneering phase. Unfortunately, initially establishment of GHP in India was faced with strong resistance from the medical personnel and health administrators who did not think beyond asylum concept of mental illness management. Due to this, till 1960, there were very few GHPUs that were initially established in collaboration with Department of Neurology and were often called as neuropsychiatric clinics. Now, All India Institute of Medical Sciences was the first GHPU unit to start postgraduate psychiatric training in 1962. Next one. Now, the current status of consultation liaison psychiatry in India. Next. In India, although the GHP units were established in 1930s, CL psychiatry has never been the main focus of training and research. In India, at most of the centers, the CL psychiatric services follows the consultation model, wherein psychiatrists evaluate and manage the patients who are referred from a physician or a surgeon. In general, it is evident that CLP services across various centers follow the consultation model for both inpatients and outpatients, in which, on the request of a physician or surgeon, the psychiatrist evaluates the patient and provides psychiatric inputs. For outpatients too, it's a consultation model that is being followed. Now, next one. Yeah, the studies from India which have evaluated the pattern of psychiatric morbidity among patients referred to CL psychiatry services suggest that across various institutes, it is delirium, self-harm, depression, substance use disorders, and stress and neurotic disorders are the most common diagnostic categories. Considering that delirium is the most common psychiatric diagnosis among patients seen in inpatient CL psychiatry service, the CL psychiatrist should collaborate closely with the physicians, surgeons, and teach them the clinical skills to identify delirium at the earliest so that appropriate management can be started at the earliest. Next one. Currently, in 3/4 of the institute in India, the CLP services are provided as on-call services, and junior resident happens to be the first-line respondent in majority of the teams. In terms of practice of CLP, the service models practiced in India have not been well described, and true liaison model is not evident from the available studies. In 2013, there has been an article which states, the article is Contemporary Issues in Liaison Psychiatry and Growing Older Adult Population in India, Experiences from an UK Initiatives. And the conclusion of the study was, Psychiatry as a specialty has been neglected at all levels in India, and service development has been scanty. The inception of the concept of liaison psychiatry in India has been almost an ancient one, but it has not raised the standards of care to any significant level. Next. Now, what could be the possible reasons? And these are the possible reasons behind the lower rate of psychiatric referrals in India. Poor knowledge about mental disorders. Incomplete training during the undergraduate level is a major barrier for their poor attention and involvement in the management of mental disorders in patients, and stigma associated with mental illness among physicians and surgeons. Other reasons for poor referrals could be negative attitude towards mental disorders or focus on physical health rather than on a holistic healthcare. It can be said that almost all psychiatric departments in India practice consultations from other departments. These are at best rudimentary. Next. First, lack of use of specific psychiatric diagnosis in about half of the referrals possibly reflects that the physician or surgeons may not be very well versed with the psychiatric disorders. Whatever I'm going to state here, I'll back up my statements. Now, the second is initiating the referral just for the need also reflects that physician or surgeon are not actually interested in knowing or managing the mental illness, and rather it reflects that referrals are made as a lack of psychiatric clearance may hinder in carrying out the procedures or may have medical legal implications. Next one. There have been number of studies and evidence-based medicines and articles published saying about the concordance. In general, there is a poor concordance between the psychiatric diagnosis made by the physician and surgeon and the psychiatrist. We often come across lot of prescriptions from a physician or surgeon stating putting on their diagnosis which we don't really agree upon. In terms of concordance, the concordance was quite low for common psychiatric disorders such as delirium and depression. However, concordance for the diagnosis of substance dependence and self-harm behavior was moderate. The studies from other part of the world also suggest that the concordance rates of diagnosis made by CL psychiatry team and the physician surgeons are low for various ICD-10 categories. These findings possibly reflect the diagnostic inaccuracy, misdiagnosis in the hand of physician or surgeons. Now, next one. There have been no major efforts at the organizational level to enhance the awareness of specialists from other disciplines with respect to the importance of mental health issues in providing holistic and comprehensive care to medically ill patients. Even Indian Psychiatric Society has recognized many subspecialty sections such as child psychiatry, geriatric psychiatry, forensic psychiatry, and biological psychiatry, but has never focused on CLP as a subspecialty. Now here comes the proof. It hurts. These are the clips that were taken from Harrison, General Medicine, and Adams, Neurology. See, there is not even a mention of consultation, liaison, psychiatry anywhere in these books. Now, I know I'm making a very strong comment, but I believe this is apt. This is what does islands of excellence in oceans of mediocrity. Next one. Now there is to back up my opinion. These are two articles that I compared. One was published in 2011, and the other one is in 2022 March. Both are published in Indian Journal of Psychiatry. If you look at it, the one in 2011 it says new clinical challenges are going to emerge, which will further enhance the role of psychiatrist who is well equipped to deal with psychological issues in medical ill subjects and has better understanding of the comorbidity. Hence, there is a need to improve CL psychiatry. Even after a decade, almost the same comment was made in the article published in 2022. It is as if we say India is still a developing country. Next one, please. So now, for better consultation, liaison psychiatry, the training in the future. Now, this is where I was really I don't know how I should express. This is the question asked by Dr. Hema Mali, my wife. The moment I heard this question, I felt like the next slide, please. Like the Abhimanyu. It is why is a fellowship necessary in CLP when it is just about referring a case. Hope by now she got some of the answers. Next one. So this is the reason consultation liaison psychiatry provides a fit vantage point for watching the changes that permit prediction of future directions in psychiatry as a medical discipline. The kind of psychiatry that the consultants practice and the type of training, skills, and professional attitudes that their work requires represent a model that is likely to prevail in psychiatry in the coming years. Next one. Next one, please. So, considering the increasing emphasis on providing person-centered care, there is a need to shift the focus of training from identifying and managing only primary psychiatric disorders to interface of psychiatry and other disciplines. The basic aim was to bring mental health professionals in close proximity with other specialists in medicine for the purpose of training and providing psychiatric care. What is evident that the CL services are mostly in line with the consultation model, in which, on receiving a referral from the physician or surgeon, a psychiatrist evaluates the patient and psychiatric inputs are provided. There is a need to sensitize and educate psychiatrists about their role in the practice of medicine beyond managing the primary psychiatric disorders. CL psychiatry, it's not about being taught, but able to teach the physicians and surgeons. Next one. So from moving from consultation model to liaison model, maybe that is how we would go ahead. Consultation model is the patient is the center of the focus. In liaison model, the consulting physician is a focal point of the liaison model, which includes teaching the physician and the clinical team about the psychological and behavioral components of the patient's problem, in addition to providing advice for the patient. Hybrid model involves psychiatrist as a part of multidisciplinary team. See, even if we think logically, as an undergraduate, we are taught about medicine, surgery, and all other specialties, but we were never taught about psychiatry per se. So imagine if we become a part of that multidisciplinary team, we have an extra edge over physicians and surgeons. That's my opinion. So again, here let's agree to disagree. So my recommendation would be consultation and liaison or a hybrid model of psychiatry is a better. Next one, please. So now the resolution. Next one, please. The relationship of psychiatry with other medical illnesses has progressed from the phases of psychodynamic understanding of medical symptoms to subsyndromal symptoms of various primary psychiatric disorders to diagnosing syndromal psychiatric disorders. Hence, an integrated approach which focuses on both the aspects, that is, psychological aspects of physical illness and physical comorbidity and its impact on psychiatric disorders, is important. During the CLP postings, the postgraduate trainees must be supervised adequately to learn skills to make proper diagnosis, how to communicate with the specialists in other disciplines, documentation from medical legal point of view, periodic review of the cases, providing psychological intervention in non-psychiatric setup, and use of psychotropic medications in medically ill participants. All the patients to be followed upon a regular basis by the CL psychiatry team till discharge or death. Now, I would like to go to my third part of presentation. Now, just a momentary pause. So, these are the musketeers. See, I know among us we have our colleagues. They are quite privileged to have good association with other specialists. And as they say, the three musketeers, all for one and one for all. They are quite privileged to say that we have a liaison neurologist and liaison physician, but sometimes the thought itself is quite disheartening. We hardly see or hear any physician or surgeon saying that here is my liaison psychiatrist. So my struggle starts now. Next one. So here, next one, please. As a loner, so these are my cases and my challenges, and here goes my ace case. So So next one, please. So let me discuss the real problems and challenges I faced. So this was on February 9, 2018. A 46-year-old ex-army man was admitted to a missionary hospital, displaying symptoms consistent with mania. Initially, I prescribed haloperidol, Prometheus, and injectables, and injection lorazepam as and when needed. Due to undetected sleep apnea, lorazepam injection administration led to ICU admission and intubation. On day 2, a consulting neurologist took over the case, dwelling into comprehensive diagnostic workups to rule out potential causes. I was briefly out of the picture but re-engaged when the patient's condition deteriorated and mood symptoms returned. After a session of ECT, I suspected obstructive sleep apnea based on brief improvements post-extubation and ECT sessions with oxygen. Now, these are the findings. The date of admission was on 9th February 2018 and date of discharge was on 28th 2018 February, and on 9th the complete blood picture was done, which was normal. There was a mild elevation of LFT because a few months back he had typhoid, episode of typhoid. So on 13th hormonal assay was done, which was normal. 13th MRI normal, brain. On 14th the CSF stains were negative. On 14th again there was a contrast MRI brain was done, which was again normal. On 15th the VDRL CSF was non-reactive. On 16th they did CSF culture, which was normal. On 19th, entire molecular biology on HSV 1 and 2 with DNA PCR was done, wherein it was not detected. Next one please. On 20th of February, the case was transferred. So taking a calculated risk, I administered 4 ECTs along with intermittent BiPAP. Despite my persistent efforts, obtaining a polysomnography assessment proved challenging. On 28th, the case was eventually transferred to Hyderabad for better treatment. And over the following month, I received calls from Kamaneni and global hospitals. However, even they were not convinced to perform a polysomnography. After a lot of struggle, the patient was admitted on 10th May 2018 to a military hospital in Pune. On the very next day, I received a call from the colonel who inquired about my diagnosis, to which I responded it was OSA-induced mania. Voila. Polysomnography was finally accepted. On 12th, the test was done and the confirmed severe OSA with significant symptoms was what the report said. And on 15th, the certificate of medical necessity for BiPAP was issued and a machine with a humidifier was procured for home use and patient was discharged on 18/5/2018. Hardly it took 8 days. Now the patient never required psychotropic medications and the family maintained contact with me. See, this entire story I was telling because look at the time span. See, if the consultation liaison psychiatry was applied here properly, maybe you would have saved enough time. So that and it would have been more cost effective. Of course, I agree that army was paying on the behalf. So next one. Now there are certain challenges within. So after confronting this case, once I inquired about, you can go to the next slide, please. So I was quite interested about this OSA, and I remember it was in Tirupati conference that I was quite interested to know about any such similar cases were confronted by our colleagues. So I really couldn't get a proper feedback. So I just leave this option open. So remember, these are some of the conditions which I believe I have seen and I've treated probably. The mixed delirium. It is a hyperactive and hypoactive delirium with a comorbid OSA, obstructive sleep apnea. Now there is again a mixed delirium with hyperammonemia, especially when you get a referral from a neurologist. It is obvious that they are AEDs are culprits because now, can you really explain that to your neurologist that anti-epileptic drugs could be the reason that there is hyperammonemia and that might have led to mixed delirium? Or even if you could explain. Now the question is how to treat. Now there again we come across alcohol withdrawal delirium with hyperammonemia. So these are definitely certain conditions which we come across but hardly you could explain this or to your physician or neurologist, but still you have to practice. Now another one, next one. See, this is again quite interesting. I have come across this classification while I was searching through for the topic. So there is a classification like baby bloomers, millennials, and new generation. You know, every 20 years the generation is changed. So the other day I was watching Made in Heaven. So suddenly the concept of homosexuality has come in. Even imagine, imagine we practice in a group where all these people we are together. There are baby boomers in our segment, Generation X, Generation Y, Generation Z, right? So how would the situation be? Isn't that a challenge to convince a baby boomer by the Generation Z that this is quite normal? So I just want to leave it for your thought. The next one. I definitely believe this is quite challenging issue. There are referrals, consultations, and in written expecting indecent favors. I know we keep calm, we don't express it out, but imagine a situation because nowadays psychiatry is being taken by a number of women. Now they get a lot of consultations, they go to different hospitals. That definitely improves their confidence and they feel so proud that their reputation is going high. Now, what if suddenly they confront a situation wherein the doctor or the hospital chairman behaving in an indecent way? Isn't that a challenge for a consultation licensed psychiatrist? This is again a question I pose. So next, this is for the sake of my PGs and for my entire team of psychiatry and department of psychiatry in GGH. So this is one case we dealt recently. So have fun. Okarada Idra Krishnulu. So it's a kind of epic.
You are not audible.
You are not audible. Sir, Phanibhushan sir, is Kiran audible, sir?
No,
sir,
not
sir.
at all.
Not వినిపించడం లేదు సార్. సార్ ఒకసారి మ్యూట్ చేసి అన్మ్యూట్ చేద్దామా సార్ సార్ని? అనిల్ గారు ఒకసారి అన్మ్యూట్ చేస్తారా?
సారే చేయాలి సార్. యాక్చువల్గా ఈ షుడ్ ట్రై నేను సెండ్ చేస్తాను. సార్ ఇప్పుడు అన్మ్యూట్ మాట్లాడండి సార్ ఒకసారి.
హలో, వినిపిస్తుందండి సార్?
సార్ మాట్లాడలేదు సార్.
కిరణ్ సార్, మీ వాయిస్ వినిపించడం లేదు సార్ మాకు. కిరణ్ సార్, మీ వాయిస్ వినిపించడం లేదు.
సార్ కిరణ్ సార్ ఒకసారి మ్యూట్ చేసి అన్మ్యూట్ చేస్తారా సార్ మీరు? సార్ వినపట్లేదు అనుకుంటా, ఒకసారి ఫోన్ చేయండి సార్ సార్కి.
ఓకే, నేను చేస్తాను.
His microphone is muted, sir.
సార్ కిరణ్ సార్, మీరు ఒకసారి అన్మ్యూట్ చేసుకోండి సార్. కిరణ్ సార్, వినిపిస్తుందా సార్?
లోకేష్ సార్ ఒకసారి మీ స్క్రీన్ షేరింగ్ కూడా ఆఫ్ చేయండి సార్ ఒకసారి.
I'll stop.
Yes, sir. Let Dr. Kiran talk, sir.
Yeah, I think we can continue discussion. Since Kiran's mobile is mute.
సార్ మీరు మాట్లాడండి సార్. కిరణ్ సార్, మీరు మాట్లాడండి సార్. మీ వాయిస్ వినిపిస్తుందా సార్?
మేబీ మన వాయిస్ కూడా వినపట్లేదు బికాస్ ఈస్ నాట్ రెస్పాండింగ్ యాక్చువల్లీ.
ఈస్ నాట్ రెస్పాండింగ్.
మళ్ళా మనం మాట్లాడుకుందాం, ఏం చేద్దాం?
కిరణ్,
ఫోన్ చేయండి.
Kiran, are you hearing us?
He is in hypoactive delirium.
Sir, if you are able to listen to our voice, please raise your hand, sir. Kiran, sir.
పని ఫోన్ చేయకూడదు.
ట్రై చేసా, అది స్విచ్ ఆఫ్ అయిన వస్తుంది.
ఇగో వేస్తాను.
Sir, nice, sir. Sir, am I audible, sir, now?
Yes.
Yes. So the story is, Okarada Edharakrishna, this happened recently. So I'll read it again. In a compelling real life scenario, a woman who had been married for 12 years with 2 children made a sudden decision to elope with a man she had met just 6 months prior. After 2 months of emotional turmoil, her husband managed to persuade her to return home. Thanks in part of the assistance of her boyfriend, who agreed to a unique arrangement. They decided to give themselves 2 years to gradually move on while preserving some strings and benefits. The husband, struggling with premature ejaculation, accepted this proposal. However, trouble arose when the wife couldn't resist contacting her former lover and began feeling envious of his wife. This emotional conflict led to conversion symptoms such as aphonia, amnesia, and weeping spells, culminating in her admission to a private hospital. On the first day, I collaborated with a neurologist and a general physician to address the case. We engaged in discussions and successfully persuaded them to admit the lady to GGH. Subsequently, we assembled a comprehensive team comprising JR, SR, consultant, social worker, counselor, advocate from Saki, and a judicial assistant to tackle every aspect of the situation. With this comprehensive treatment and counseling, the patient was discharged from the government hospital within just 7 days, making a successful outcome. Icing on the cake was the husband also received the necessary pharmacotherapy and counseling for his PME. And now this emphasizes the importance of holistic care in consultation liaison services, and it was a happy ending. Next slide. Now, this next one, please. Yes. So this is what I feel. If you're not taught, you will not know. If you don't see, you will not know. If you don't understand, you will not know. And if you don't want to see, you don't want to understand, you will never know. The next one, sir. Thank you, sir. Lokesh garu, thank you so much. The next slide. This is my last slide. Thank you so much. Sir.
Phanibhushan, sir.
Yeah. So some kind of unique presentation, and old timers like us may not be able to understand some of the slides or thoughts you're having. So definite generation gap is around. But what I have learned over last 3.5 decades, as far as the CL psychiatry is, in other words, the psychosomatic medicines. See, medically ill patients, when they have psychiatric symptoms, okay, how to consult and how to liaise and how to take care of the drug interactions and how to educate the so-called physicians or surgeons, because only when they are having a problem in dealing with these patients, then only they will look for a psychiatrist to tide over the crisis. That is a very common approach. The other thing is chronic psychiatrically ill patients having a medical problem, then the doctor also will realize a known psychiatric case. So what should we do? That is a second category. Third one is the people with litigant paranoid, people with personality disorders, uncooperative patients, extremely phobic or anxious patients. So all these patients, when they suffer from medical condition, either medical or surgical or going to surgery, going for investigations or anything, then also they create problems for the various consultants. Then also these physicians remember the role of psychologists or psychiatric nurse or team of CL psychiatry, but preferably in our arena, psychiatrists to start with. This is the third category. Fourth one is complex medical condition and difficult decision to make, and very subtle psychiatric issues and life-threatening situations, and that is another area where they try to involve us. So all these four things we keep seeing day in and day out. So we have definitely, it's a beautiful subject and my pet subject also, because this is a basis of, in fact, the NMHP, one of the aims and objectives of the National Medical thing is to incorporate psychiatry into general medical health care. So that was the dream which started in 1982, and slowly people are understanding the importance of psychiatrists in day-to-day dealing with hospitalized patients, outpatients, and capacity building or decision making, or nowadays actually we are seeing more of these difficult patients thanks to Google. We are getting more and more involvement with the other specialists. So this is what definitely it is evolving, and we need to have some kind of expertise. As Kiran and Raman Rao has told, we need to have a sound basic knowledge on other subjects, so that sometimes when they miss out, it is our duty to tell them that they are going in the wrong direction. This is going to be the right one. So you should not feel ashamed of pointing out mistake if it is there in the interest of the patient. Then only, if you are assertive, then only people will understand, people will recognize your worth, and that credibility will improve. So for that, you should be more knowledgeable. So this is what I have observed, and Dr. Raman Rao and others can share their opinion. I will stop here and let the discussion start.
So wonderful presentation by Kiran. And in fact, I too have come across patients with OSA posing problems. Like once I have seen one severe maniac when he was in probably in 50s or 60s. And then he was snoring like hell. Then I told them, do you have that CPAP machine? They said, doctor, we have it with us. So immediately we have attached it and the patient improved within no time. So it's a wonderful experience. Like, and of course, I keep seeing lots of patients, and some of them even being prescribed tranquilizers by our own colleagues. I have seen, and that patient is not improving at all. And OAC is a clinical diagnosis. Basically, we don't need any polysomnography also, because very classically is he will not be sleeping in the night and getting disturbed too often, and daytime he will be sleeping. And usually, most of them are very obese and they have snoring history and all that. Nowadays, polysomnography is being done routinely everywhere. There is a technician, and he comes and does it, and then it's not a big issue at all. But we should be very, very careful because because sometimes they come only for insomnia with cardiac disease and all that. And if you prescribe a tranquilizer, that is a hell of the problem. So one of the take home messages, and that Kiran is excellent way of dealing with CL psychiatry. I appreciate him. All the best.
Thank you, sir. Thank you, sir.
Anybody else who can initiate?
Sir, sometimes even I would like to submit things, sir. Sometimes even the patient doesn't realize that he's having OSA, sir.
Yeah, it's not the domain of the patient to realize that he has a OSA or not.
So
But
when
once, no, because I liaised with one of the pulmonologists here who was trained in a good institution, and routinely we prescribe the CPAP machine through him because most of our patients, they're highly obese even though they're young, and they get the recurrence of psychosis and all that. But I insist them to consult him and to get prescribed a CPAP machine, which is not very expensive.
Sir, somehow, unfortunately, even when detecting these cases, even the ABG would be normal, sir, most often. So it really becomes a task to convince the basic physicians that he might be having this problem of OSA.
See, I
So,
think it's a clinical diagnosis mostly. I
yes.
think this polysomnography and all that is only just an objective evidence, that's all.
So just to throw light on that, we have come across two more cases recently, sir, in the past 2 years. Lokesh sir knows him pretty well because we diagnosed that case as mania. He happens to be a journalist. So he, after that, has been using medication, mood stabilizers for the past 2 years and all. And there has never been an episode of mania again. But wife started complaining that he's getting some symptoms of narcolepsy, almost like he's dozing off at work and all. That's when again we suspected why can't it be some sort of OSA. Then we prescribed polysomnography because we have that sleep lab in GGH, and it again turned out to be a severe OSA. So for the past 6 months or 8 months, he's only on bupropion and modafinil, sir. Because he wasn't ready to buy a BiPAP machine. So we are trying him on bupropion and modafinil, and he seems fine.
Basically, it is a sleep deprivation, whatever may be the mode of sleep deprivation, but that is the cause for the maniac episodes, most of the patients. So if you can see that they have comfortable sleep, fine. But the basic underlying mood disorder has to be treated. Just because we prescribe a CPAP machine, it won't really solve the problem. That is only one of the modalities of inducing the sleep. That's all.
So, sir, there has been an article which says OSA induced psychosis. So I say, why can't it be OSA induced mania? Basically, maybe he wasn't
No,
having a mood disorder at all.
it is the sleep deprivation that precipitates the mania or psychosis. So sleep deprivation should be tackled depending upon the cause. Suppose if it were to be OSA, you need to prescribe a machine like CPAP machine. If it were to be another cause, we have to treat that cause. But the
Yes.
basic, if there is a family history of mood disorder, if the strong past history of mood disorders, we need to prescribe a mood stabilizer or an antipsychotic which may be non-sedating.
I totally agree with what Raman Rao is telling. See, one of these seasonal affective disorders, when they have a lot of stress related to seasonal extra work, they have sleep deprivation, and that's the time they develop hypomania or manic disorders. At least I have a dozen cases of these seasonal affective disorders following this mirchiyard business, because in the peak business period they work day and night, and because of sleep deprivation they get into mania or hypomanic episodes. So sleep deprivation definitely, OSA, you're all aware that obstructive sleep apnea can produce terrible sleep difficulties. That could be one of the reasons for your case. And I know you did a lot of work on these BiPAP and these sleep deprivation and these mood disorders. Go ahead with that research project. But another thing I want to tell you is always you should be very careful with the COPD cases. Psychotropic medications, particularly in ICU cases, when they are having a very precarious balance, even a small dose of benzodiazepine or any psychotropic medication can be the last straw on the camel's back, and they go into cyanotic or say saturations can fall down. So you must be very careful in dealing with medically ill patients, particularly any these psychopharmacology is going to be a very complex issue. We need to teach our students not to overdo things, particularly in medically ill geriatric patients, people with multiple problems and precarious positions, because they are very trigger happy and they prescribe too many and too large doses, so that the patient lands up in ICU for due to fall in saturations.
Sir, how do you tackle this hyperammonemia, sir? Question to Raman Rao, sir. When you come across such cases.
Sodium valproate is known to produce hyperammonemia, especially in the children. But I have seen only one case, but really I didn't follow up that case. But once I stopped the drug, the patient is improved. He is a mentally subnormal intelligence, being treated by one of our colleagues in Vijayawada, and he was put on. He is an adolescent person. High doses of sodium valproate. He developed delirium. So once we stopped that sodium valproate and put him on other drugs, he has improved completely.
Have you come across any case which is already in delirium and you noticed the hyperammonemia, sir? A delirious case.
I don't routinely screen for ammonia levels.
Thank you, sir.
It's very difficult
What about your
to.
experience? Yeah.
It's very difficult to measure ammonia levels. If you clinically, if you think the patient is drowsy, better use lactulose and reduce the dose.
Okay, sir.
Funny, why don't you ask Ranjit to say a word of thanks?
Sir, may I, sir?
Yeah, please.
So thank you one and all, sir.
Kiran, let me congratulate you. You can wear a cap of last slide's cap. You can wear now.
Yes, sir.
So I just liked one sentence from your presentation. Liaison helps rather than consultation. That is the beautiful point which I take it. No, because all chronic medically ill and then organic cases are definitely associated all kinds of psychological problems. That where psychiatrist's role would definitely be there. So it is the psychiatrist duty or responsibility to educate all your fellow colleagues. Keep informing that these are the things you would see when you see these psychological problems. You do refer to us back. So that is the thing. I think keep informed all the neurologists, endocrinologists, physicians that these are the common problems you might come across, and then let's have a look on them. So I think finally congratulate Dr. V V Kiran. I think South Zone is watching you. I think you did a good job. Thank you, Kiran, and thank you all the IPS AP branch office bearers to have this kind of beautiful program today. Thank you.
Thank you, sir.
Can I give the vote of thanks, sir? Can I give the vote of thanks now, sir?
Yeah, please, go ahead.
Yeah.
We are waiting for that.
Okay, sir. I would like to thank Dr. V V Kiran for his out-of-the-box and excellent presentation. I think I chose this topic and it has been given to the right person. I would like to thank Dr. Phanibhushan Garu for chairing the session so well. I would like to thank CME committee members, Dr. GV Ramana Rao Garu and I Vishal Garu for managing this program so well. I would like to thank the President and Secretary, Dr. I Narasimha Rao Garu and Dr. Shalishmira Garu for this program. I would like to thank the Crescent Pharma for conducting this program. Thank you everyone for your participation.
Yeah. Good night. Thank you.
Good night, everybody.
Good night, sir. Good night, sir.